Hi, good afternoon. My name is Kanesvaran. I'm currently a senior consultant medical oncologist at the National Cancer Centre, Singapore. I'd like to thank the Oncology Club of Bangladesh, organizing committee of this virtual preceptorship, for inviting me to share with you about the management of metastatic, non-metastatic or M0 CRPC. How do we approach it? These are my disclosures. So this is the outline of my talk. I'm going to give you an overview of the metastatic prostate cancer treatment landscape and then define what non-metastatic or M0 CRPC is. I'll then deep dive into the trial data for non-metastatic CRPC, what the guidelines say, followed by APCCC statement, and finally, I will summarize. So this is currently the management of systemic treatment in metastatic prostate cancer. So you can see here there are three large groups. On top here is the non-metastatic CRPC. There's also metastatic hormone-sensitive prostate cancer below here. And finally, all of them have a common endpoint where they all become metastatic castrate-resistant prostate cancer. So for this talk, I'm going to zero in on three of those drugs that I mentioned there in the treatment of non-metastatic CRPC. So I thought it'd be a good way to start with a case that you can relate to. So I am going to present one of my patients, Mr. PD, 68-year-old gentleman, presented to urology with a raised screening PSA of 11.2. He was found to have an enlarged prostate on DRE. Trus biopsy revealed a 4+3 acina adenocarcinoma. MRI prostate shows localized prostate cancer with no disease outside by staging scans. So he decided, at least at that point in time, the treatment decision was RT plus ADT. He had very good response, PSA nadir of 0.1, and he had ADT planned for about 18 months post radiotherapy. Now, 1 year later, before even the 18 months ended, PSA started to rise, and it reached a level of 4.0. At that point in time, conventional imaging like CT and bone scan showed no evidence of disease. Underlying all of this, he had hypertension, also a history of coronary artery bypass graft 5 years ago. He was on aspirin and 2 hypertensives. What would you choose for this patient? Would you just add another hormonal therapy like Enza and APA or non-metastatic CRPC patient, because that's what he is at this point in time? Continue ADT till the mets appear, do a PSMA PET scan, which is widely available in many countries, or add chemo or an older ARTA like ABI. So let's review what NMCRPC is. So as you can see here, clearly it is a unique space. So these are basically patients who, number one, have biochemical progression while on ADT, which is factor number 1 here. Serum testosterone must be below 50 nanogram per deciliter, and there's no evidence of metastasis, like this patient. Basically, there are 2 ways they can become like this. One, they've had primary treatment, and then they relapse with only PSA rising, and they've started on ADT with the PSA continuing to rise with no distant mets. Another group were not suitable for curative treatment. So the primary was there, they've started ADT, that means they're not suitable for RT or surgery. And then while on ADT, PSA starts to rise, but again, there's no metastatic disease. So what are the potential benefits for treating them so early when there's no metastatic disease or measurable disease? Now, we know once you become metastatic, it's a deadly disease. If we can delay the development of MCRPC, we probably buy them time. The other thing is when there's better ARTA nowadays with tolerable toxicity profile and can be used for longer compared to chemotherapy. So you can potentially delay the need for chemotherapy. The third thing is there's a very low disease burden. In fact, outside of the primary, there's no disease burden elsewhere that can be seen by conventional imaging. So these are the potential benefits for treating it early on before it becomes metastatic. Now, who are the patients who are high risk? So as you can see here, Matthew Smith's study, this was done when looking at patients, the role of some bone modulating agents some years ago. But basically this study shows, if you can see here, the relative risk of death actually increases when the PSA doubling time becomes shorter. In fact, the cutoff there was about 8 months. And as you can see after that, if it's shorter than 8 months, the PSA doubling time, the risk of bone mets or death actually increases substantially. So from this, we have a clue about patients who are high risk non-metastatic CRPC. And then the second terminology that's relatively new that came into the picture in the non-metastatic CRPC setting is this term called metastasis-free survival. So there are a lot of challenges in conducting trials, especially very early on in prostate cancer, because coming up with OS is extremely difficult. You've got to wait for long periods of time. So clinical trial designers look at surrogate endpoints. We've seen this happen in colon cancer, colorectal cancer before, PFS as a surrogate of OS, or DFS as a surrogate of OS. Now here they look at MFS as an endpoint of non-metastatic CRPC surrogate. Now MFS has been associated with OS before in patients with recurrent prostate cancer with deferred ADT. So these were patients who were hormone sensitive, and clearly there was an independent link. Patients whose MFS were less than 3 years actually did better in terms of overall survival. Did worse in terms of overall survival compared to those who were more than 3 years. So clearly in the hormone sensitive setting, it was linked to OS. In the localized prostate cancer setting, it's linked to OS as well, as shown by this study. So there are a number of studies in other settings that have shown a link of MFS to OS. So it made a lot of sense to use that as an endpoint in the studies that I'm going to discuss in a very short while. Now, these studies are very, very similar in terms of design. They all had about 1,500 patients. They were M0 CRPC. PSA doubling time was less than 10 months, so they were a high-risk group. And they were good ECOG performance status of 0 and 1. So these studies were either using enza, apalutamide, or darolutamide. And they were compared against placebo because standard of care at that point was to wait until there was metastatic sites developing. And that's when you start treatment. Now, primary endpoint-wise, as I mentioned, it was MFS. And I explained to you why MFS was chosen. It was shown to be a good surrogate of OS in other settings, in localized prostate cancer and hormone-sensitive prostate cancer. So it made a lot of sense to use it in this setting as well. Now, there were other endpoints like OS, and fortunately now, enough time has passed. We actually have OS data as well. So we can discuss that in a short while. The first of these trials was PROSPER. So as I mentioned, eligibility, very similar as what I described. So I'm going to go in straight into the study. Patients were randomized to receive the full dose of enzalutamide, 160 milligrams per day, plus ADT versus just ADT alone. And the primary endpoint was MFS. As you can see here, the primary endpoint was achieved. In fact, at about 2 years, about 70% of the patients were still in the ADT arm alone, was still alive. But a significant number more were alive or did not, more than alive, did not get any metastatic disease at that point in time. And the median MFS was 36.6 months, and it's the time taken before they developed mets was nearly 3 years in the trial arm versus just half of that in the ADT alone arm. Now, in terms of overall survival, as you can see at that point in time, there was no data, but last year, ASCO 2020, now we have data. As you can see here, there was a 27% reduction in the risk of death. So median overall survival was 67 months. So there's more than 5 years versus just 56 months for the placebo arm. So it's clearly there's a significant survival benefit for patients who got onto the enzalutamide arm versus placebo. When they look at subgroup, nearly all subgroups benefited. I think those that use bone targeting agents, the numbers were too small. So you can see it crossing 1. The other thing was in terms of geography, rest of the world, also the numbers were slightly smaller. So that seemed to cross 1 as well. But for all the other groups, there seemed to be a significant benefit for the use of enzalutamide in these patients. Now, subsequently, and this is something you've got to take into account when looking at overall survival, is that the placebo group, about 2/3 of them actually received treatment, and most of them receive androgen receptor targeting agents, whether it's AbbVie, a few of them receive enza, some receive chemo. While in the enza group, only about 1/3 receive subsequent therapy. And in spite of the placebo group, more of them receiving second-line therapy, the benefits still persisted. So that tells you that starting these drugs earlier does make a lot of sense. So based on that, enzalutamide is now one of the standards of care in non-metastatic CRPC. And the adverse events were pretty consistent with what we know of enzalutamide in the AFFIRM and PREVAIL trials in the CRPC setting. Now, the next drug is apalutamide. Again, very similar study design. Again, randomized 2:1, just like the PROSPER as well. But apalutamide dose is 240 milligrams, also 4 tablets of 60 milligrams each, and MFS was the primary endpoint. And when this was first read out in 2018, as you can see here, the hazard ratio is 0.28, and there was a significant reduction in mortality, 72% to be exact, very similar to what we saw in enzalutamide. But however, overall survival data was not mature at that point in time. ASCO last year, same time, PROSPER had OS readout, Spartan had OS readout as well. You can see here 59.9 months for the placebo arm versus 73.6 months. If you recall, it was 67 months, but you shouldn't compare head to head because they're very different studies. Hazard ratio wise, pretty much similar as well. Aramis, the newest of the 3 drugs, was presented a bit later in 2019. ASCO GU, darolutamide was used standard dose, 1,200 milligrams. Again, randomized 2:1 and compared against placebo. And the final analysis was OS, which was read out at the same time last year as well at ASCO 2020. So initial readout, MFS benefit, hazard ratio of 0.41 with 40 months for darolutamide versus placebo. Placebo here did slightly better, 18.4 months. Secondary endpoint was not reached when it was first presented at ASCO GU 2019, 2 years ago. But in ASCO last year, it was presented with a significant survival benefit, hazard ratio 0.69. As you can see here, at 3 years, 83% of them were still alive versus just 77% in the placebo arm. So another drug with a 31% reduction in the risk of death, a bit higher than some of the other groups. But again, I warn you, you can't compare this head to head. So if you put them all side by side, as you can see here, clearly, they're all about the same, about 70-odd%. Darolutamide in terms of MFS slightly lower. However, all these data is now superseded by the overall survival data. When you look at toxicities, some of the things we worry about for this class of drug in general is fatigue and falls. And of these 3 drugs, clearly you can see here, darolutamide seemed to have the least in terms of fatigue, which is 12.1%. In terms of falls, also was just 4.2%, significantly lower than apalutamide and enzalutamide. However, darolutamide is not available in nearly most countries in Asia, so we have to wait and see before trying it out to confirm whether this is actually true or not. Now, what do the guidelines say? The guidelines actually offer all 3 options as category 1 options if you're high risk. If you're not, if the PSA doubling time is more than 10, then you can just observe and then only treat them when they have metastatic disease. What about APCCC? I don't know whether some of you are familiar. This is the Advanced Prostate Cancer Consensus Conference. So this group was formed in 2015. And every 2 years, we meet to discuss some of the key issues in prostate cancer. And these are divided into questions. Last year, there were about nearly 130 questions. And all of us voted on these questions to see what we will do in our own clinical practice. In Asia, there were 4 of us selected. I was fortunate to be one of them. And I'm going to discuss some of the questions we decided on. So you can see that world-leading experts here, including Johan Di Pono, Nick James, so many big names from the US, Karim Fizazi from Europe. So when do you recommend initiating additional treatment for MOCRPC? As you can see here, in 2015, when they first held this conference, at that time, there was no data on any of these drugs. Option 4, which was based on combination of PSA doubling time and absolute PSA, which they suggested you may want to consider additional treatment, even though there was no data at that point in time. And I suspect this was the case because many of the experts in that panel were part of the clinical trials and they were expecting to see some benefit. Now, fast forward 4 years, in 2019, when we voted for this, nearly everyone, 86% said they would use one of these drugs. And only 7% said they would not use anything at all. So clearly now, I think the standard of care is to use one of these therapies in non-metastatic CRPC. However, the game changer has been PSMA PET, the type or choice of imaging. As you can see here in this study, PSMA PET was positive in 196 out of 200 patients who were supposed to be non-metastatic CRPC. by conventional imaging. So this tells you that even though when you do bone scan and CT scan, it's negative, when you do a PSMA PET for this high-risk group of patients, they're probably going to have some disease either in the lymph node, and about 55% of them had M1 disease. So all in, 90% of them actually had some disease. Now, what are the challenges? One, PSMA PET is going to come into the picture, and in India it's as cheap as $150 US. So that's relatively affordable. In fact, some of my Indian colleagues say it's cheaper to do PSMA PET than to do CT and bone scan. So once you do that, then some of these patients may be classified as M1 CRPC. So they shouldn't be M0. The other thing is a lot of those drugs that are listed are very expensive. And there's another ARTA called AbbVie, which is very cheap. And now it's actually very affordable because it's generic. Now, can we use it? The problem is we don't have clinical trial data. However, in countries where access is a problem, it might be worth a try considering the use of AbbVie in those kind of situations. As I mentioned, access is still limited and darolutamide is not available in most countries in Asia. So what did we do for Mr. PD? We had a discussion. At the end, he went with enzalutamide because apalutamide is very new at that point in time. He had some fatigue. We recommended him to undergo an exercise program. He has overcome it now with a structured exercise program and is still using the drug up to date. So in summary, non-metastatic CRPC is a relatively uncommon presentation of CRPC. In the conventional imaging era, it was about 5 to 7% of the population of CRPC who had MCRPC. However, now that number may be even smaller. As you can see, most of them, if you use a PSMA PET, especially the high-risk group, actually have some METs. So that number may actually be smaller. Now, there's clearly an MFS and OS benefit with enza, APA, and darolutamide. Hence, that becomes the standard of care for this group of patients. But a key consideration in many Asian countries is cost and access. Some of these drugs are not available. If they're available, they're very expensive. You have alternatives, but the alternative hasn't been tested, which is abiraterone. So that's an area, perhaps some research could be done to justify the use of that drug in this setting. So with that, I hope I've given you some insight into the treatment of non-metastatic CRPC, and I'm open to questions in a short while. Thank you very much.